In this video, we're going to run through what is a fairly common problem when it comes to bottom surgery, and that's vaginal stenosis or narrowing of the new vaginal canal. My name is Dr. Saif Gallagher. I'm a plastic and reconstructive surgeon with a special interest in gender affirmation surgery based here in Miami. And so, unfortunately, vaginal stenosis or avoiding vaginal stenosis can be difficult in some patients. Some patients, we create the new anatomy, and even if they barely dilate, as I've rarely heard reported, the canal stays open and functional without any trouble. And then in other patients, about 10% of patients, they can really struggle. But this is what we do if a patient is doing okay, is dilating fine, and then is running into difficulty. Talk to your own individual surgeon. They'll have different recommendations, different techniques at times, but this is what happens in my practice, just to give you an idea. So first of all, we're going to want to do a consult, ideally face-to-face. A lot of our patients are out of town, so sometimes we'll do a virtual consult, look at some pictures and figure out what's going on, because we really want to figure out, do we have a functional problem or is there a mechanical problem? So is there something causing an obstruction that is not going to go away on its own, or is it a problem with technique or that the pelvic floor itself won't relax? And it can actually be sometimes a little bit difficult to discern which of the two is happening. And the reason is the pelvic floor is very powerful, and there is a whole field of pelvic floor physical therapy where the physical therapists are really experts at helping you control and relax that pelvic floor. And so in some cases, when patients are struggling with dilation, referral to a pelvic floor physical therapist can really make all the difference. And I always say, in an ideal world, everybody would have a pelvic floor physical therapist after vaginoplasty, but that's not always possible. But regardless of where you are, I found that pelvic floor physical therapists really do have a lot of expertise, even if they haven't necessarily treated a transfeminine patient before or a patient with vaginoplasty. So that can be a really big resource over here in the functional group, and it's just a matter of learning how to relax that pelvic floor and different tips and tricks to dilation. Now, reasons why you may have a structural problem, two main reasons here. So first of all, granulation tissue. Granulation tissue is the bane of vaginoplasty recovery, and basically what it means really in layman's terms is that there's a bit too much healing going on, that when, like, around where the suture lines closed up, we have this red kind of beefy tissue that is annoying and actually can hurt, and you can get it on the outside of the vagina, the inside of the vagina, and oftentimes folks who develop it once will develop it a few more times in the first year after surgery. Now, thankfully, it is a relatively easy fix in that it can be cauterized, and so that doesn't involve a surgery. Typically we'll use something like silver nitrate, but again, talk to your individual surgeon. If it is granulation tissue, I typically use silver nitrate, and oftentimes we'll do a topical estrogen cream which can soften the area as well. Sometimes, however, it can be scar tissue that can improve with dilation, sometimes with the estrogen creams as well, but sometimes we may need to think about doing the labiaplasty earlier on and getting rid of that scar tissue. And I had a few patients recently, couple of patients I can think of, who this was the issue. They were champion dilators, they were doing fabulous, and around about 4 months after surgery began to notice that they were losing the girth first, is what they noticed. They were maintaining their depth fine with the dilators, but having a bit more difficulty, and in one case down to just being able to pass a finger. So in that situation, what we usually will do is bring up the date of the labiaplasty. Typically, I prefer to do the second stage of the surgery, or the labiaplasty, after 6 months after the first. But when we're in this situation, usually the scar tissue is at the entrance of the vagina, and we can identify it and open things up. And then there is that group of patients where things will be narrowed down, particularly if a patient loses depth and is narrowed on the inside. That can be more difficult to treat, and sometimes will need some sort of redo surgery for that. In a lot of cases, in folks who haven't lost a lot of time in dilation, we can sometimes open it up again at the labiaplasty. We'll pack it again, we'll place a catheter again at that point. But in certain cases, a simple opening up may not be possible. In those situations, it's usually folks who haven't been able to dilate for quite some time, and they lose depth. So that's why we're always emphasizing to folks the importance of dilation after bottom surgery. So that's just a quick run through of vaginal stenosis. It is one of the banes of bottom surgery. There's no one technique such as peritoneal vaginoplasty that prevents it, or penile inversion vaginoplasty. That's why everybody has to dilate in order to try and avoid this. But there are some good tips and tricks which I've mentioned in this. But again, always talk to your own surgeon. This is not medical advice.